Alcohol in and of itself is a teratogen, or something that can cause a birth defect. It's going to cause malformations to that developing fetus if the exposure is heavy enough and long enough to those developing cells. So wherever water can go inside the human body, alcohol can also go. And so it can impact any developing cell during the different developmental phases of that pregnancy. It can easily cross the placenta and into the area where the baby is developing. So the baby is not safe from any amount of alcohol. And once the baby's been affected, it's one of those issues where if there's brain injury, that's not necessarily can change. We can do early intervention to try to work with the child to offset some of that disability, but it is what we would call a permanent disability. If you look here at this fetal developmental chart, it's a nice piece to kind of get an idea of what's happening during that developmental phase of the pregnancy. So the very first 2 weeks, it's called the period of the ovum. And we used to think that that was a period that was very safe. But actually now research in the animal labs have shown that even during those first 2 weeks, that those cells are impacted by alcohol exposure. So it's really important that women plan pregnancies and don't drink prior to trying to conceive or get pregnant. If you look at the colors on this chart, the very dark purple is what's most impacted by alcohol, where it's very sensitive to the alcohol. And then the lighter pink color says that it's still sensitive to exposure, but it's not quite as bad as the early phase. So if you look here, the one organ that's impacted by prenatal alcohol throughout the entire pregnancy is the central nervous system, or the brain. And again, that's why we call this a behavioral teratogen, alcohol, because it impacts the brain, which then impacts the behavior and patterns. We also see the heart is impacted early, arms and legs, eyes are throughout the pregnancy, as well as the ears are fairly common through the pregnancy. So you'll see different areas of individuals that are more impacted than others. And that's just something to keep in mind when we talk about kind of trying to identify this in clinics. So again, it's the longer the exposure, the heavier the amount of exposure, the more likely the effect and problems over time. I also just want to point out that the face of this developing fetus is very early in the pregnancy, within the first few weeks. So if that mother's drinking early on, binge drinking heavily, we may see the face, but if she just happened to not drink during that period, then we wouldn't see the face, which is pretty common when we're looking at prenatal exposure. What's the prevalence or incidence of FASDs in the United States? And that's kind of been all over the map. We used to think it was about 0.2 to 1.5 cases per thousand. But since then, we've come to see better research, better surveillance to really kind of pick up, and looking at children in a first grade class with a more recent study estimates that we're probably more like 2 to 5% of school-age children have some effect from prenatal alcohol exposure. The societal costs are quite expensive when you start to look at this. Just looking at the annual cost associated with drinking while pregnant in the United States, it's about $5.5 billion. And that includes problems with drinking during pregnancy, such as hospitalization or decreased productivity, as well as increased costs for care and services of the affected infant and children, such as special ed and mental health, that type of thing. Also, we look at just the lifetime cost for an infant, and that can be approximately $2 million. And that was really looked at the Medicaid costs also, where children with an FAS in 2011 were about 9 times higher cost than a child without an FAS. So it's a very costly disorder and something that is very preventable. So the second section is going to talk more about the diagnostic resources for FASD. And so we really want to just kind of have an idea of what is an FASD evaluation and the diagnostic side to it. I also wanted to preface, I'm not sure if I missed it in a slide, but what I'm telling you again, because every state's different about what an MA can or can't do, it's really important to consult your state guidelines as well as your practice specific to make sure that whatever I'm saying is something that's true within your office. So I don't want to be giving advice that goes against your practice act. So just to make that clear. So fetal alcohol spectrum disorder has one condition called fetal alcohol syndrome, and it has three characteristic features that are associated with it. And one is they have a specific facial abnormality, which we would call in the field dysmorphology or dysmorphic face. And that's something that you wouldn't say in front of the client, but it's something that you may talk with your physician about. The growth deficiency, meaning that they're at or below the 10th percentile in growth. And then again, central nervous system problems. So some type of brain injury has occurred that would be able to be picked up on either developmental exams or some kind of an IQ testing or other speech and language tests, different tests of that sort. So here's a classic face of fetal alcohol spectrum disorder, of FAS. And I really want to preface the idea that this is not a common within the area of alcohol exposure. The majority of individuals do not have the face. So it's something to be aware of, but it's also something to pay attention to some of the other things that are going on. So you see that between the arrows of A and B on the eye, that is your the philtrum and a palpebral fissure there, and the distance between those two, the A and the B, is kind of shortened and makes the face between the two eyes look farther apart. You'll also notice the smooth philtrum, which I started to allude to, and then the thin upper lip. So that's your three cardinal features that you would look for fetal alcohol syndrome. And then we have growth deficiency. So again, when you're looking at a child on a growth chart, you're looking for a growth curve. You're not looking for the flat line. That means that they're failure to thrive. But these kiddos could be very small for their size. So you want to look to see if they're at or below the 10th percentile in either height or weight. And you want to measure that at the same age, same time point. And then the third area is your central nervous system, which is the brain injury, and we can have lots of different things that happen. So we may see a smaller than normal head size, again at or below the 10th percentile, or changes in the structure. So that might be seen on an MRI or CAT scan kind of imaging. And then also we may see neurological deficits, which could include poor coordination, muscle control, infants having difficulty sucking, that type of thing. And then we can have functional abilities where oftentimes this is what we see, where they're just not functioning at what's expected for their age, their school, or their circumstances. So again, that can be seen in areas like executive function, cognitive deficits or delays, motor function delays, so they're slow to talk, walk, sit up, crawl, and then attentional problems or even hyperactivity, and then problems with social skills. So again, if we were to look at this individual, their first diagnosis might be failure to thrive because they're so tiny, and maybe the second diagnosis, if we're not asking the question about alcohol exposure, might be something like hyperactivity or some attention deficit disorder type of diagnosis. The non-alcohol versus the alcohol-affected brain in this photo shows a very significant difference between the two structures of the brain. The child on the left was a baby that died of a respiratory illness at 6 weeks, and the one on the right was a child that had alcohol exposure, a fairly significant amounts of alcohol exposure, where the child just wasn't able to survive. And you can see that alcohol is very damaging to the structures of the developing brain. When we look at this, we also see a lot of co-occurring behavioral and mental health issues that come up. So I kind of alluded to that diagnosis of attention deficit hyperactivity disorder. We also see a lot of anxiety and mood disorders, especially depression. And this was seen in Anne Streisku's Cardinal study back in 1996, where they followed a group of across a longitudinal study, and we saw high incidence of individuals with mental health problems, as well as they have a higher than normal rate of substance use and abuse, and they also tended to be in trouble with the law more often. And some of this has to do with executive function issues. Again, high risk sexual behaviors and sexual abuse. And not to say that every individual that is alcohol exposed is going to have this, but oftentimes their developmental age may be significantly different than their physical age. So you may have a 14-year-old body with a action and behavior of maybe that of a 9 or 10-year-old. So you may see some inappropriate sexual acting out for the age. And again, it's based on the disability more than it is that they're a predator. So that's something to keep in mind. And then the homelessness and truancy was very high with these individuals. And if in adulthood, a large portion of these individuals were not able to live independently and or maintain significant employment. There's 5 types or concerns that can bring an individual into your healthcare professions and could lead to maybe an assessment of an FASD. So it's something to kind of look at as an individual comes in. I know that oftentimes the school will send an individual in for an evaluation for attention deficit hyperactivity. So that could be something, but again, there are other developmental or behavioral concerns. So that might be one that they come in, or the parent may come in complaining that they're having difficulty in parenting, the child's not following rules, or the kid is very angry, has a lot of emotional outbursts, that type of thing. They may also come in with the cardinal facial features that we talked about. So again, thinking about, you know, the flattened palpebral fissure, the thin upper lip, and the shortened palpebral fissure, sorry, and the philtrum, flattening of the philtrum and the thinning of the upper lip. They may also have some kind of growth deficiency, so maybe they're just looking a lot smaller for their age than you would expect, and again, basing this on their family history and parents. And then you also, if you're screening, which we're going to encourage you to be doing, you might get some information around alcohol use during the pregnancy. So again, it just depends on who's bringing the child into clinic. If it's a foster adopt mom, they may not have that information, but there may be suspect. So again, if you do know for sure that mom drank, it's important to document that so that that goes with the child's chart in case there is a need for diagnosis. And then again, the family just self-reports that there was problems around either they were drinking or they're concerned that their child might have a fetal alcohol spectrum disorder. So again, there's lots of resources, and NOFAS is a great place to go if you're trying to find where to go to get resources if you have someone in clinic that you suspect. The importance of early identification is kind of been alluded to here, but it's really important that these kids are picked up and get an early diagnosis so that we can start early intervention. In Ian Streisglu's study, again, one of the most protective factors of preventing secondary disabilities or problems that happen, such as when a child is it has a primary diagnosis of fetal alcohol syndrome or ARND, the secondary disability might be trouble staying in school, dropout, depression, anxiety, trouble with the law, those type of things. The best predictor of not having the secondary disabilities was a diagnosis before the age of 6 years of age. So that's a really important piece to keep in mind when you're working with families. And then again, early diagnosis means early workup on the child and lots of help with the family and kids. It's also, you can try to decrease some of those effects with early diagnosis and really working with the family to have realistic expectations of what's going on with their child. These are all important aspects to consider with an early diagnosis. So sometimes they're too young, we can't get them, we can't get a formal diagnosis yet, but we can always put them into the school side of the 0 to 3 programs and get early intervention started. it won't be a diagnosis, but it'll start the process. In our third section, we're really going to be looking at how do we screen and what are some of the techniques that might be used to determine an alcohol-exposed pregnancy. What do you do to try to reduce the incidence of this? And that's kind of where my passion comes in. I'm a very strong proponent of prevention. And, you know, a lot of clinics will talk about what do I do? How do I talk to my pregnant patient that's drinking? And I will talk to them about that, but I really wish they would call and say, how do I talk to my women of childbearing age who are preconception, who aren't pregnant yet? How do I talk to them about this risk and their alcohol use? So you're going to hear some information about that, and I hope that you get a good idea here about some ways that you might talk with the woman. One of the things that we're going to look at here are just what is excessive drinking. So up in the upper left quadrant, you see a woman and a man, and you see different drinking rates. So one of the things that we know is that women can handle less alcohol than men. Over time, their body gets sicker, it telescopes, and they can get alcoholism faster. So the women's drinking rates need to be less than men. So we think of a binge drink as 4 or more drinks, or another way to say it is no more than 3 drinks at one sitting. So again, for men, it's just 1 more drink. So they can drink 5 or more drinks at a sitting, or no more than 4 drinks at one sitting. So that seems a little kind of a lot, and it is, but again, with that developing fetus, you really don't want to have any more than that amount of alcohol and not know you're pregnant, because that can be very damaging to that developing fetus. In the lower left quadrant, you'll see the pregnant woman, and any alcohol used by a pregnant woman is considered risk drinking or excessive drinking. So we're really looking at a 0 tolerance to pregnancy drinking. I know that there's the information out there that you may have heard that, you know, a small amount of alcohol is okay, but that is not the standard of care. So I just want to point that out. And then in your upper right quadrant are anyone underneath the drinking age of 21 years of age. We would consider any amount of drinking as risk drinking because they're not of the legal age. For one, the brain's still developing, so it can still be very impacted by alcohol exposure. And then in your bottom right quadrant is the risk drinking for heavy drinking. And so we look at risk drinking in 2 phases, one as the binge drink, that stacking of drinks, and then the other is heavy drinking over time. And where we found the most impact on these developing fetuses was drinking more than 7 drinks in a week, or 8 or more drinks for women. And for men, heavy drinking is considered more than 14 drinks in a week, or 15 drinks or more. So men can drink quite a bit more than women and not have as much impact. And there's lots of other risk areas when we start to get into heavy drinking. It's not just about drinking that impacts that developing fetus, but it impacts the body, puts it at greater risk for cancers, puts at greater risk for date rape, for other kinds of alcohol unintended injuries, DUIs, that type of thing. So when we talk about drinking, we also want to talk about what is a standard drink. So when we're talking with our patients or our clients about alcohol, we want to all be talking about the same thing. So an example, the first woman I worked with, one of the first women I worked with in a home visitation program, and she was telling me that she had 2 drinks in the evening. So I started to ask her about what her glass was like, and it was actually more like this malt liquor glass here that you see in the picture, and she was drinking that with vodka and orange juice. And so when we started to look at really how much alcohol she was drinking, instead of 2 drinks, it was probably more like 5 drinks, and then times 2, so 10 drinks in an evening. So there can be quite a bit of alcohol differences, so you really want to clarify. Again, regular 12-ounce can of beer, it typically has about 5% alcohol, but if you're going to the microbreweries, that alcohol content can shift significantly. We have the malt liquor, which is a little higher alcohol, and it's also in a larger glass, so you have a difference there. And then you have your wine, your table wine, which is about 5 ounces, and then your shot, 1.5 shots, is about 40% alcohol. But all of these drinks have the same amount of absolute alcohol. So if you were to compare alcohol to alcohol across these drinks, they would all be considered a standard drink. So again, just kind of paying attention to what that looks like. So the guideline on alcohol use during pregnancy, we believe, is very clear, although we do have providers out there that are still giving unclear information to their women. But basically, coming out of the U.S. Surgeon General's advisory, it was in 2005, went out and said that women should not drink during pregnancy, no alcohol. And if a woman is pregnant and has consumed, that she should stop as soon as she knows she's pregnant to minimize further risk. And then a woman who is considered becoming pregnant should abstain from alcohol to begin with. And again, that's very true because of the animal study in 2000 that showed that even that early alcohol exposure during those, before the egg is implanted, is still being harmed by the alcohol in utero. The American College of OB/GYNs, the American Academy of Pediatrics, and the Center for Disease Control and Prevention all say no alcohol use during pregnancy or while trying to conceive. So again, the licensing bodies out there, their best practice is no alcohol use during pregnancy. There's really two ways to kind of prevent an alcohol-exposed pregnancy, and really what we're looking at here is to reduce risk drinking. So women of preconception age they can become pregnant, but they're not pregnant yet. We would want them to, if they choose to drink below risk levels. So we wouldn't want them to drink in excessive amounts in case they unintentionally became pregnant. And we would want them to, drink no more than 3 drinks at a sitting and no more than 7 drinks in a week total. If they were to become pregnant, of course, that number would go to zero amount of alcohol. And the other way is to prevent a pregnancy. So some women want to continue to drink, they like partying, they're not interested in changing their drinking pattern, then we would look for like a long-term contraception that could help prevent a pregnancy while they're choosing to continue that lifestyle. And then optimally, women would choose to do both so that they're not harming their body as well as preventing an alcohol-exposed pregnancy. So one of the ways that we do this is through alcohol screening and brief intervention. And so in CDC language, it's called ASBI, alcohol screening brief intervention. And in SAMHSA, another group that does this work, they call it SBIRT, which some of you may have heard of, a screening, brief intervention, and referral to treatment. But they're both basically doing the same thing. We're looking for that risk level. With this project, we're looking at risk for an alcohol-exposed pregnancy rather than risk for addiction. So that's something to keep in mind. But we're looking for that risky drinking patterns. And then we're going to do a brief screen, and we'll talk about some of those screens in a little bit. And then we're going to do a brief intervention with most, and some we will refer on to treatment that need more intensive work. So if you look at your typical clinic in the United States, this is an average. So your neighborhood, your state may have very different rates. So it's important to go to your like your state health department and see what their PRAMS data looks like or what their BRFS data looks like, so you know exactly what the drinking rates are in your state or your community. But in general, about 80% of the population drinks at low risk levels. So they're either abstinent or they're drinking below risk levels. So that's encouraging, because that person, you can get them in clinic, you can tell them you're doing a great job, keep doing what you're doing. If you do decide to get pregnant, make sure to stop drinking altogether if they're not already, and or to plan that pregnancy to make sure they don't have the alcohol exposure. And then you'll see the yellow area, that 16% is where we really look at that risk or hazardous drinking. And that's the group that's going to do very well with a brief intervention. Oftentimes, the earlier we catch them, and the sooner we do the brief interventions, the better outcomes we have. So, you know, when you're in a clinic setting, you're busy, you're rushed, and somebody's drinking 4 drinks at a sitting, it's really easy to say, oh, well, that's just one above the risk level, but really that's your person that's going to be most amenable to that brief intervention. So you really want to pay attention and really give good recommendations and advice. And then there'll be that small percentage of patients that are dependent, and they do need to be referred on to treatment. You can still provide a brief intervention. It could be a way of starting the treatment referral work, but again, just paying attention and looking at what does your clinic population look like. It could be very different than this. We want to screen all women of childbearing age, and it's ideally to screen at every visit. So you're constantly asking the question, and that's for a couple of reasons. One, you want to pick up any kind of discrepancy where somebody all of a sudden has had a crisis in their life and maybe they're drinking more than they normally would be, so that you can get them back on track, or somebody that's been abstinent in recovery and has suddenly relapsed, so you can get them kind of back on track. But again, we want to screen all women of childbearing age. We can't assume to know which people are the ones that should be screened based on their looks or their race or their ethnicity. So we really don't know, because alcohol is used in all societies across all socioeconomic backgrounds. Some of the simple screening questions that happen, again, SBI screening can be a single question, which just identifies who's binge drinking if you have a very short clinic, or it could be as much as doing a formal screen like an audit or a craft or a TACE or a tweak are some of the screens out there. You can look those up, or you can actually email us and we can get you copies of screening tools. But the most important thing I've found is looking for that dose, the how much and how frequent. So frequency and dose. So you really want to get to those 2 questions. And again, non-pregnant this is one way to ask the question. On any single occasion during the past 3 months, have you had more than 3 drinks containing alcohol? Again, that question is okay, especially if you're in a fast crowd. It's better than do you drink or you don't drink, do you? But again, it's also could tell the person that, oh, you're looking for that 3 drinks. So if they're nervous, they might say something different. And then the pregnant patient, have you had a drink since you found out you were pregnant? Again, it's an okay question, but I like to ask prior to knowing you're pregnant, how often did you drink? And then once you found out you were pregnant, what was your intent to do around that drinking? And then what were you able to do? So there's lots of ways to talk to the patient, the clients about this, and find out what their drinking is, their drinking patterns, and how frequent. Brief interventions are simply that. They're brief, they don't take very long, they can be done right there next to the patient while you're doing other things like talking about, you know, their whatever, like doing a temperature and doing a blood pressure and actually asking some questions and screening and then doing a quick brief intervention. Some examples are just to give advice. Advising a woman who drinks moderately and is pregnant or is contemplating pregnancy to abstain. So just giving that, you know, we now know that it's harmful to the developing fetus to be exposed to any amount of alcohol, and it's best if we abstain. Help a woman weigh the costs and benefits of drinking. So, you know, what are some good things about your drinking? And what are some not so good things about your drinking? So they start to really kind of talk about that and feel comfortable. And then again, help a woman maintain that motivation to reduce or eliminate drinking by reinforcing the benefits of an alcohol-free pregnancy. So again, learning some of the motivational interviewing techniques that can help motivate this client, and I'm sure that that will be offered later in a different series down the road. And then I am now going to turn this over to Kathy. I don't know if I'm going too fast for this webinar or not. So Kathy, I'll go ahead and let you have it.
Pam, I just wanted to also thank certainly the folks from Mountain Plains and certainly the AAMA and everyone who's sitting on the webinar waiting for me to sign back in. Thank you so much for attending and for your patience. So in this section, we're going to talk about how to improve communication with patients who may be using alcohol, especially during pregnancy. So, no woman drinks because she wants to hurt her baby. I know the knee-jerk reaction to hearing that someone has a child with effects from drinking during pregnancy is to lock her up, that she's a criminal and that she did something bad on purpose. You know, I have been involved with NOFAS since the very early days when NOFAS was first forming, and I've met probably thousands of women who have drank during pregnancy and may or may not have a child with effects. But I've never met a woman who purposely drank to harm her child. So during this section, we'll talk more about why a woman would drink during pregnancy or have a child with an FASD. And it may surprise some to know the answer to this question. So, according to the CDC, the highest alcohol use during pregnancy is among women aged 35 to 44 years of age. And it's college graduates. So there's a tendency to kind of stereotype or to assume that this is only occurring in certain populations of people and with certain kinds of mothers. So, you know, one of the issues that we have to be really careful of is the stigma and to stereotype people. And certainly if medical professionals assume that they should only inquire out, you know, a patient's alcohol use only with certain patients that look a certain way, certainly we can lose an opportunity to prevent an FASD in a pregnancy. So one of the issues with FASD is that we say that this is, well, some say it's 100% preventable. But the problem is that in our culture, women drink. Well, not just women, but women and men drink. And so it's kind of a very socially acceptable thing to do when you go out for dinner or go out with friends or what have you. And, you know, there's just, you know, a lot of myths and biases around people that kind of get caught in the trap, if you will. So, you know, and because of this stigma, we believe at NOFAS it really has prevented us from moving forward. You know, we first learned about fetal alcohol syndrome that Pam had given us an overview on, the probably most well-known disorder from drinking during pregnancy, but certainly it's also the most rare disorder that a person would have. But we first learned about FAS in 1973. And, you know, here we are with 43, 44 years later, and we haven't really come a long way in terms of prevention, or at least those of us that work in prevention wish that more women really took heed and you know, stopped drinking before they got pregnant. So there's many myths and biases around people that suffer with alcohol use disorders or substance use disorders, formerly known as alcoholism, addiction. And many physicians and healthcare professionals just are not educated about substance use disorders. And when you're not educated about something, it's really difficult to ask the questions because you don't feel confident sometimes in your ability to do so. You'll hear a little more about the Circle of Hope program in this presentation, but for right now, let me just tell you, we have a program designed for birth mothers of children with FASD. So we started the Circle of Hope program in 2004, and it was really to prevent the next pregnancy being prenatally exposed to alcohol. And so the Circle of Hope provides mentorship and support. We try to help get women into treatment and try to help keep women sober that might be suffering with addiction, and answer questions for women and just help them to deal with guilt and remorse of use during pregnancy. But we surveyed some of our members, 93 members in 2012, and asked women why they drank during pregnancy. And so here, the breakdown here is on this slide. You know, about 40%, almost half of them, really didn't have the right information about drinking during pregnancy. Now, granted, some of our birth mothers are older. They had their children even before 1973, before the information came out. So for a lot of our women, they really didn't have the information because it wasn't even out yet. But, you know, some were social drinkers and drank before they knew they were pregnant. And as soon as they found out, they stopped. Well, guess what? If you're drinking and you're pregnant and you stop when you're 6 weeks pregnant, you can still cause effects in the developing embryo. Some people thought it was okay to drink as long as they weren't drinking too much, or they were drinking things like beer and wine and not hard liquor, quote unquote. We actually had a couple women who were advised by their doctors to drink. One woman in particular that I know personally very well was pregnant with twins, and she had lost several pregnancies before this, and the doctor had her in bed throughout the end of the pregnancy and had her drinking every day. Her twin boys that are now 6 years old both have fetal alcohol syndrome. And some were just never advised not to drink. Now, almost 60% believe that the reason that they drank during pregnancy was because they were suffering with addiction. And so some knew that they shouldn't drink, but they just weren't able to stop. Some were, and these were self-reports, by the way. They were open-ended questions. Some reported that they were addicted to other drugs and were in active addiction and were drinking too. Some were just dealing with the shame of drinking and didn't want to tell anyone that they were drinking. Some reported that they were an alcoholic, but they drank before they knew they were pregnant. But then when they found out, they did stop and got into treatment. And some could not access treatment. So that's kind of the breakdown. And that's always the question that we get asked is, why would any woman in her right mind drink during pregnancy, especially with the information? And, you know, when we ask questions like that, it's usually because they're suffering with addiction problems. So, and it's important to note that most of the women that have children with an FASD used other drugs as well. So they were using alcohol and other drugs. And sometimes when women are addicted to drugs like cocaine or heroin, drugs that seem much more dangerous or damaging to the fetus or socially unacceptable, they continue to drink. So oftentimes they'll stop using drugs and drink more during pregnancy, again, which is, you know, based in just not having the right information. So of course, in understanding addiction, you know, we have to understand, you know, that for most there are genetic factors. Most people, you can trace either parents or grandparents that have suffered with some sort of addiction to some sort of alcohol or certainly other drugs. Environmental factors certainly play a role, and according to research, first-time drug use as well. So again, there's lots of factors in who becomes addicted and who doesn't, just like any other disease. Certainly if you're genetically wired, the brain kicks in and reinforces the use. So drinking heavily doesn't cause someone to become an alcoholic. They drink heavily because they are an alcoholic, because their brain, when they have that second and third drink, that brain is telling them, wow, that feels really good, let's have another drink. Where if you don't have this disease, your brain is telling you, don't drink anymore because we're feeling pretty sick right now. You know, and you have to use, though, to find out if you have this disease. So that's one of the issues here, is that you have to start at some point in order to tax that genetic susceptibility. Tolerance, having a built-in higher tolerance to alcohol and other drugs is one of the early symptoms, and certainly experiencing withdrawal, because as time goes on, a person becomes addicted, and so when you wake up in the morning, you start to experience withdrawal or become ill. Alcohol and other drugs, as the disease progresses, will become the priority over everything. So over, for women, over their children, over their marriage, or their relationships, all their family, social relationships, their physical health, maybe their spiritual values, and use despite consequences will be the norm. So obviously, women who suffer with addiction or alcoholism, alcohol use disorders, need support to stop drinking, especially if they're pregnant. And, you know, there seems to be another kind of myth out there that there are no treatment resources for women who are pregnant or women who have children. Now, granted, some communities there's going to be better access than others. But the federal government and state funding, there are treatment centers in every state. And in most states, pregnant women will take priority if there is a waiting line. If you cannot access treatment, and we have resources on our resource directory through SAMHSA's Center for Substance Abuse Treatment, where you can find state-funded treatment in your area, or you can contact NOFAS, and we will do everything we can to try to assist you in obtaining treatment. So again, I don't want to paint the picture that every single woman that gives birth to a child with an FASD is an alcoholic or addicted. Now, granted, many have had children reported they're not an alcoholic, but later have come to terms with the fact that they are indeed someone who has experienced addiction. One of the hallmarks of addiction is denial. And sometimes people that are experiencing it are the last to really understand that's what's going on. But there are a group of women that are social drinkers, and women that maybe drink heavily. Maybe it's New Year's Eve or their birthday, or they go on a cruise and they drink excessively for a period of time and then stop, and have also had children with effects. So I just wanted to be clear about that. But if you are in a position where you're talking to women, certainly talking to a woman who has used during pregnancy, who may be worried about the fact that she used, you know, we need to be gentle and to be non-judgmental. If we want to get the information and have them share honestly, they have to be safe. We have to create a relationship with our patients. We want to stick to the facts about addiction and provide them with information like you would any other disease in a very matter-of-fact manner. And remember that you may be the only person that could help motivate them to change. And in every community, even if you don't know where a treatment center is, and I would urge you to know the treatment centers in your area, but there's always Alcoholics Anonymous, Narcotics Anonymous. There are free places that you can refer people and maybe even say, hey, I don't know, you might maybe, you know, check out a 12-step program and see, you know, what you think, you know, that sort of thing. If she's struggling with whether or not she might be unable to stop on her own. So again, it's important to be well educated about the effects of both alcohol and other drugs so that you can give her the best information and remind her that you really care about her health and the health of her unborn baby as well as her entire family. And so, you know, again, if you create a safe environment and create a safe talking environment with women, they will you know, be very honest, and it may even surprise you how honest they are. But they, you know, for a lot of these women, nobody has given them the time of day in a long time, because it's very common for women to suffer with low self-esteem and all kinds of emotional, you know, trauma and things. So, you know, when they find somebody that seems to care about them, they can, they'll really respond very positively quickly. So again, we want to really watch the words, and words really do matter with this issue. It's always better to talk about how the fetus is affected rather than focus on, you know, FASD occurs when a pregnant woman drinks. So that's one of the things at NOFAS we feel strongly about. We want more women, we want to prevent as many future alcohol exposed pregnancies as possible. We just believe if it's the language continues to be as stigmatizing as it has been in the past 40 years or so, we just aren't going to get very far. We'll be in about the same place in another 40 years. And also to not talk about children like, oh, do you have an FASD kid? We'll hear that a lot. So it's, you know, do you have a child that has been diagnosed with FASD? Do you have a child with fetal alcohol syndrome? So we recommend person first language. So again, you know, the stigma, you know, prevents women from talking to a medical assistant, to a nurse, to a physician, to anybody that they see as an authority figure, because you know, they're very concerned about what you think about them, and kind of painting a picture that's going to cause you to put them in a different box, to feel even lower than they might already feel. And providers sometimes don't diagnose an FASD. We have physicians that won't diagnose FASD because they don't want to stigmatize the woman or the child. So it's kind of twofold with the stigma. Women don't want to disclose their use, and providers sometimes don't even want to diagnose. So those are some of the things we're trying to address at NOFAS. So again, we want to, you know, to help women to understand that we're trying to help their child. If we're empathetic and compassionate, we can put a mother at ease. And I always recommend, when you can, to use self-disclosure. You may have someone in your family who has suffered with addiction and maybe, you know, is in recovery. Maybe you have a family member or neighbor who has a child with a disability. Maybe you have lived through something. So when it's appropriate, I know that each session is certainly unique. Or maybe talk about other clients that you have seen along the way, and talk about how they were able to deal with their own addiction and kind of get to the other end. So I think if you can use stories that women, again, can also be put at ease with those kinds of stories, that it's not all doom and gloom. So again, just, you know, to look at the role of the medical assistant that we're really asking of you is to just avoid assumptions and biases about women. You know, you never know what their life has been like. And a lot of the women we work with have stories that would really raise the hair on the back of your neck. A lot of them have been traumatized, and they're survivors, and they're doing the best that they can. We want to ask at every visit about their alcohol use. Pam talked about the screening, and if it's a prenatal environment, then we recommend that you ask at every single prenatal visit, and certainly, again, every annual visit. Again, having resources available and being knowledgeable about who can get into those treatment centers and insurance and all that sort of thing is going to really help. And again, consider having culturally relevant material, certainly language, cultural differences, and all those sorts of things matter. And again, if you need resources, you can contact NOFAS, and we will do our best to connect you with the best resources out there. So just a quick story. Why I do what I do is because of this little girl on the screen. This is my daughter, Carly. She's about 4 years old here. Carly has full-blown fetal alcohol syndrome. She's got specific facial features. She was very small. We called her Beanie, String Beanie, because she would eat and just never gained weight. People would say, oh, she's so cute and tiny. She's like a little pixie. And she has brain damage from being exposed to alcohol. And Carly's story is that, you know, I had Carly in 1973, the year that the first piece of American literature came out describing the fetal alcohol syndrome. So here's a picture of all three of my children in 1977. And in 1977, I had all three of these kids and drank throughout every one of those pregnancies. And some won't believe, but I had no idea you shouldn't drink during pregnancy. I had my first two children before the literature even came out, and I had my youngest, Aaron, in 1977, and not one physician ever talked to me about that. You know, I was a Woodstock girl, I was a hippie chick, and I was using marijuana and other drugs, and when I got pregnant, I always quit using drugs and just drank cheap wine, and because that's what I could afford, and always went for prenatal care, and not one person ever mentioned that you weren't supposed to drink. So I happily drank through all of those pregnancies and had no idea that I shouldn't be drinking. I didn't drink every day. I was very young when I had my first baby, and very young, well, when I had all three of them, but I had Danny when I was 17. I was a welfare teenage mom, and I got my health care at community health centers and prenatal environments for teens, high-risk pregnancies. And I'm sure I had a lot of interaction with medical assistants. And I don't recall during those times anyone ever talking to me about my alcohol use. And anyway, so I had three children exposed, had no idea that Carly had FAS. I left the father of those children. I was married for many years with him, and then I left him and ended up marrying again, and all very unhealthy relationships, all kind of rooted in addiction, and married a man who was, you know, using a lot of alcohol and drugs, and married him and had two children. And I'm sad to say I went on to, I got pregnant 2 other times, and went on to drink during those pregnancies in the early 80s, and my fourth baby died at birth, and my last child, a little girl, died when she was only a few months old, and they said she just stopped breathing from sudden infant death syndrome, and told me that sometimes babies just stop breathing. So I'm here to tell you the reason that I do the work that I do is because it's a very painful thing to go through. And I don't want any other young woman, young couple, young parents to ever have to go through what my family had to go through. And because of ignorance and because of lack of intervention. Thankfully today, I am a woman with 33 years of recovery from addiction. I finally I got sober after my baby died. My last child died, and it took me a couple years to figure out that my then 15-year-old daughter Carly had fetal alcohol syndrome and not cerebral palsy. And when she was diagnosed, I started volunteering for NOFAS, the National Organization on FAS. And I haven't stopped yet. So I've been doing this work for 30 some odd years, and I'm grateful that I'm able to have a platform to be able to tell a very sad story that I hope will teach others that this can happen to anybody. It can happen to, you know, somebody that is not a hurtful person and somebody that only drinks on weekends, because when I was pregnant with those three kids, that was pretty much my drinking patterns. I was more of a weekend drinker and didn't drink during the week. Even though I say, you know, I'm an alcoholic, some people think, oh, she drank every day. No, I didn't drink every day when I was younger. That did come though later with progression. So there you go. And that's why we started the Circle of Hope. And there is my contact information, mitchell@nofas.org. I would so love it if you would refer women who may be drinking, who may need help finding treatment, women who have had children, who are afraid, who are ashamed, that need support, that need a mentor. We are happy to provide that support and do everything we can to build women back up and to help them recover, because it's a pretty tough thing when you realize something you did harmed your own child. And again, one of the campaigns that we're very proud of is our Stamp Out Stigma campaign. And we're trying to do our best to get everyone to really think about language so that we can get women to tell the truth, because we know the earlier a person who with an FASD is diagnosed, the better for them. If you go again to nofas.org, we have a state-by-state directory. You can click on your state. You can find resources for women who may be drinking, but also resources for an FASD diagnosis, for professionals that may be FASD informed. We try to keep a current directory of FASD informed professionals that, you know, can help with, you know, adults, children, you name it, we try to list it and try to be very current about that. I would encourage all of you to sign up for the NOFAS Roundup. It's a weekly newsletter that comes out on Mondays, and it's everything FASD, and we can also feature things you may be doing. We have all kinds of fact sheets that are downloadable, curriculum, posters, and all that sort of thing. We provide webinars and trainings, and also we house archived webinars that are free, that you can learn more about FASD on our website. We also have a Facebook. If you just go and put in the National Organization on Fetal Alcohol Syndrome, Twitter, we have Twitter chats. And probably the most popular feature of our website is our YouTube site, where Andy Catcher has interviewed and created videos of all kinds of people whose lives have been affected by FASD, or and researchers that have done the research, clinical folks, you name it, they're on there, and it is really a great way to learn about the issue. So, in closing, just a few take-home messages. FASD is an umbrella term, and it's meant to refer to all of the many disorders that can occur. Again, remembering this is a spectrum disorder. It's all about when a woman drinks, how much a woman drinks during pregnancy, and what those effects may be. And there's other factors as well, like diet, nutrition, and other things that are being researched. Any organ in the body that is forming when the exposure occurs can be affected, but certainly the brain is developing throughout the pregnancy, and the organ that we are most concerned about. And again, there's no safe time to drink during pregnancy, there's no safe type of alcohol, and there's no safe amount. And certainly all of us today agree that prevention is key, and it's much better than having to go and find a cure. And in actuality, there really isn't a cure, but there's treatment and strategies. But we want to prevent, because we certainly don't want any other woman to have the story that I just told you in this day and age. But unfortunately, I hear it still all too often. We want all healthcare providers and centers, environments, doctors' offices, what have you, to screen all women of childbearing age and help to encourage women to talk about their alcohol consumption and to kind of normalize it and put them at ease so that they can talk. And again, I just want to thank you guys. I'm sorry for the little glitch I had with getting thrown off of the webinar platform. Thank you so much. And I'm going to go ahead and turn it over now to Carolyn Edney, who I think is going to facilitate some of the questions.
Yes, Kathy, thank you so much. And before we get into the questions, I did want to read a couple of comments that came in after you shared your story. Charlene Couch, who is a former AAMA president, said, "Thank you, Kathy, for sharing your story. It was inspiring." Stacy said, "Wow, thank you for sharing. Granted, I'm less than 2 weeks postpartum. I'm bawling. You are brave and strong." And Cindy said, "Thanks for sharing your story, Kathy." So there's a lot of people who are appreciative in our audience today and connected with your story. So thank you for being vulnerable and sharing that with us.
Thank you.
All right, we have a lot of questions to go through, and we have a little less than 15 minutes. So I am going to just go ahead and read these off, and I will go ahead and ask Pam and Kathy to answer. And I will be reading them in the way that they came in. So the first question that I will read came in at the beginning of the presentation. And although it may have been answered, I just want everybody to feel like they got their questions answered. So the first one comes from Stephanie, and she asks, "Are there known developmental delays with women who didn't know they were pregnant and drank the first 4 to 6 weeks from conception?" So Pam, can you go ahead and answer that?
Sure. It's drinking is a dose quantity issue. And so depending on how much she drank, we can definitely see developmental delays, the same effects, the executive function delays, problems with behavior, managing behavior, that type of thing can definitely show up. If she drank very lightly, we may not notice anything. It just depends. And then some women, like Kathy alluded to, because of nutritional status, even when they don't drink heavily, can have kids that are quite impacted when that alcohol exposure comes along.
Okay, great. Kathy, did you have anything you wanted to add?
No, that's great. Thank you, Pam.
Okay, great. The next question comes from Patricia, and I'm going to ask both of you to provide a response to this to see if you've encountered this before. She asks, are low set ears also a physical manifestation of FAS? So Kathy, have you seen that before?
Yes, actually my daughter has low set ears, and I think that is something seen more with fetal alcohol syndrome.
Agreed. This is Pam. Definitely, it can be a sign, but like anything, in and of itself, a low set ear or even a flattening of the philtrum does not necessarily 100% mean it was from alcohol. So it's important to have that drinking history along with the issue that you're seeing.
Pam, I have a question for you. Amanda is asking, if a woman is considering pregnancy, how long before she starts trying should she stop drinking alcohol?
That's a great question. And to be honest, I don't think we really have the answer yet. We know from the animal research that even doing a heavy binge drink a few weeks prior to that animal then conceiving can impact it with epigenetic impacts, which is different than fetal alcohol syndrome. So I think, giving your body a good chance to clear and be healthy and be nutritionally healthy prior to trying to conceive is going to be really important.
Okay, Kathy, I have a question for you. Rebecca is asking, why don't we hear much about this, alluding to alcohol use during pregnancy and the effects it has on a developing baby, and also alcohol use in general with regards to women? It seems like we hear more about smoking. What are your thoughts on that?
Well, it's a great question. And I can tell you, I don't have the answer to that. I wish we did as well. I actually saw an ad today, a PSA from the CDC on smoking during pregnancy and causing birth defects and infant death. I don't know the answer to it. I really do wish that all of the government agencies would put more out there on PSAs. For NOFAS, we are a nonprofit charity, and to do public service announcements, it's very expensive, and we just don't have the resources. But it is something that I think we need to do more to get the word out. And unfortunately, alcohol, even though we know that it causes the worst, the most severe effects, even more than heroin and opioids and cocaine, because it is a teratogen. It's just interesting that it seems to fall short of reaching the public, and it may have to do with the fact that it's legal and people like to drink, and sometimes people don't want to hear it about it.
Thanks, Kathy. This is Pam. I also just wanted to add, one of the other big concerns or issues is the universities and colleges are not training the professional bodies out there about this, or not to the degree that they should be, I believe. So I think we're trying to rectify that with some of the training centers, but I think that's another area why the information's not out there.
Okay, Melissa has a two-part question. She says, what should we tell the patients that believe the new information that 1 to 2 glasses a week of alcohol is okay? And furthermore, how do we deliver this information in a way that will not make the patient feel as the bad guy for their misinformation? So Pam, do you want to take a shot at that? And then Kathy will have you chime in.
Sure. I think one of the things to say, it's hard to prove that lower level drinking is harmful to that developing fetus with the human baby. But if you go to the animal research, it's very easy to prove. And so we know in the animal research that even small amounts of alcohol exposure can affect that developing fetus. So that would be the first response way that I might talk to that patient, is even though it's hard to say that it's absolutely harming that human baby, the animal research is very clear that it is. And then I would say, based on not understanding the information correctly, I can see where you thought it was okay to have a few drinks, but it's really important now that you know that you do not drink during pregnancy.
Another great question. Thanks, Pam. If you go to the NOFAS website, we have a wonderful resource there that references all of the current literature on moderate alcohol use and some really brilliant summaries written by some of the researchers. So I would, get that information. I agree with Pam. I mean, you want to normalize it. And again, it's like, well, this could have happened to anyone. You're not a monster. You didn't do this on purpose if somebody has already drank. But here's one of the things. When we prepare women that may be planning a pregnancy, we do recommend to stop drinking, both partners to stop drinking 2 months prior, just to get their systems cleared out. And we want, the family, the partner to have the baby, with the mother, for those that, are in relationships. But the other piece is, the saddest thing for me is when I have women call, and I get these calls all the time from women who maybe drank 1 or 2 glasses of wine and then found that they were pregnant and then stopped. And they'll call and they're sobbing and they're calling me and they're hysterical because their son or daughter has just been diagnosed like with autism or something, a learning disability or something. And they're convinced it's because they drank during pregnancy. So 2 parts to this is, number one, we don't want people to drink moderately, because I don't want anybody to go through that grief and fear and remorse that is probably just unfounded. Okay? So for a lot of these women, that 1 or 2 drinks probably has absolutely nothing to do with the diagnosis. So there's lots of reasons not to drink moderately, but get the true facts as on the animal research. And don't put yourself at risk. If you don't drink anything at all, you won't have to worry, because plenty of things can happen when we have a baby.
Mm-hmm.
All right. Our next question comes from Richard and Karen. They both asked different questions, but they're similar. Essentially, how does the male's intake of alcohol play a factor in this at conception or sperm formation? So how does the father's drinking have an effect on the pregnancy?
So this is Pam. So there's some new emerging evidence with the epigenetic research that the epigenetic form of that sperm is changed. And so an example of an epigenetic change might be you have a marker like on a mouse that was supposed to have blonde hair, and the alcohol changed that epigenetic profile to where now the mouse is having a brown-haired pup. So we don't really know all the impact, but we do know that alcohol absolutely impacts the sperm and its epigenetic profile. So there's definitely reason for the male to stop drinking, like Kathy said, a good couple months prior to pregnancy. The advantage with the male is that the sperm are made all the time. They're ongoingly being made. So if you quit drinking, get yourself healthy, the sperm should be healthy. The female, on the other hand, those eggs are in there and have been in there through her entire life. So there's some epigenetic changes that could have occurred there that may not be able to be rectified at some point. But it's not the fetal alcohol spectrum disorder, at least as we know it today. That may change in the field upcoming, but for now it's still the woman's drinking is what's causing that.
Okay, we do have a couple of minutes until the webinar closes. Pam and Kathy, would you be willing to stay an extra 3 to 5 minutes to answer all these questions?
Sure. And
okay.
This is Kathy. Can I just make one point that I probably didn't make when I shared my story? One of the things that NIAAA and actually NIH has been researching is alcohol use during pregnancy as a major causal factor of both fetal and infant death, including SIDS. And we do have a YouTube video on that with Dr. Ken Warren discussing that. And so I wanted to be very clear that everyone understood that I think both of my children that did die in infancy died as a direct consequence of being prenatally exposed to alcohol. And to also note that research takes time, and it's really difficult for those of us that want to get out there and prevent and work with people and are the people. So I just wanted to make those points.
And before I go on to the next question, I did want to mention, for those of you who can't stay on for the rest of the questions, we will be sending certificates with the CEUs on them within the next 7 to 10 days, and they will come to the email address you used to register for this webinar event. All right, so our next question is, how do we get services for a mother who is illegally here and afraid to get help? That's from Tony. Kathy, do you have any input?
Well, it would depend on where they're at and what resources. For instance, I live in Maryland, and there is a hospital that I would refer a woman that would fall into that category to, but I don't know. I'd have to know more about what region of the United States and what community you were in.
Yes, and this is Pam. I know that I've reached out to Catholic Charities and even people in the community of that person who's here illegally that might be looked at as a kind of a key informant, an important person in that community. They often have resources that we don't know about.
Yeah, but mine is also a Catholic hospital, so that would be the first place to look.
All right, Yesenia is asking, is there any blood test or labs that can be done to detect a fetal alcohol spectrum disorder?
That's a great question. I know everybody would love that because, you know, it's so easy when you can test the blood and say, okay, this is what occurred. To this point, we really don't have, I mean, there is a blood spot test that can look to see that there was drinking. We can definitely check meconium to see some traces of alcohol within that for a certain time period. But again, to actually do a formal diagnosis of the child, no, it's a multi-system team that does the diagnosis, including a physician, speech and language, neuropsychology, and occupational and physical therapy all come together and look at these children from different aspects to give a formal diagnosis. At least that's your best way. You can also go, if you don't have a good diagnostic capacity, you could get from a clinical psychologist in your area, or go to each of those individual folks separately to get their workup and then go to the physician. So hopefully that answers the question.
Okay, next up, Yesenia is asking, I have several patients who ask how safe it is to use marijuana. What are the side effects with marijuana? My doctor normally says there is not enough information on marijuana use and they should stop. Kathy, do you have any information on this?
You know, what I would say is there is newer research, and that is being looked into. There is newer research that has come out that is finding that women that use marijuana and use alcohol have infants that are more severely affected. I can't reference the exact research or researches. It probably is on our website, and if it's not, I'll be sure that it's posted up there. But yeah, I think marijuana is probably very dangerous to use during pregnancy.
Yeah, that's great, Kathy. That's true. And actually, I was just had an update from the field at the RSA conference, Research Society on Alcoholism, and they talked about the combination of the two drugs, the alcohol and the marijuana, significantly impact that developing fetus more. But there is some emerging research coming out that, you know, marijuana does have impact on that developing fetus. Definitely, I don't know the particulars, but I do know that there are definitely some problems that children are experiencing, especially with behavior in school. I do know that kids that smoke marijuana are real high incidence for some of the psycho effects later, like having difficulty like being diagnosed schizophrenia in early adolescence. So there's definitely some things to watch out for. And like you said, the research is just now emerging because they're doing a lot of studies here in Colorado based on the legalization of marijuana. So they're also putting a lot of money into the research. So I would really follow if you go on to PubMed in Google, you can go in there and Google some of the more current articles and look for that research.
And Rebecca has a related question. She's asking, or she's stating that the provider that she works with provides OB care, and many of their patients stop drinking alcohol when they find out that they are pregnant, but they continue to use drugs. Is there anything that NOFAS can do to help, or information they can provide?
Well, absolutely, yes. So that's very interesting. I usually hear the opposite, where women stop using drugs and continue to use alcohol. And whoever asked the question, you can certainly email me. And we are modifying. We just actually expanded our mission to include other substances of use. So we will be developing new materials, but if I certainly knew what kinds of information you needed, I could direct you to resources that are already developed, and certainly would love to chat anyway to find out what you're seeing.
And Kathy, that's true in our community too. We are having a lot of women that when they realize they're pregnant or want to become pregnant, quit drinking and go to marijuana because they know of the harm of alcohol.
So Lillian and Jane have similar questions. They are wondering about women who are drinking after they've given birth and they are breastfeeding. What are your thoughts on that? Pam, do you want to weigh in?
Well, alcohol still enters the breast milk and goes into that fetus, and the fetus brain is still developing. It has significant growth that occurs postnatally for several years. And so, again, you're still exposing that brain to alcohol, which would be inadvisable. And I know some physicians recommend a pump and dump, but again, you really have to know what this person's doing. So if you're not really doing a good assessment and really understand the rate of drinking that she's really doing, that can be a dangerous recommendation, because most physicians are not substance abuse counselors. They don't know how to do a good, thorough substance abuse assessment. So that recommendation, you might think she's just drinking 1 or 2 drinks and you're advising her to pump and dump and not breastfeed for 3 hours, when in fact she may be drinking very alcoholically and may have high levels of alcohol still on board at 3 hours. So again, it's really important to know how much she's drinking, and really advising. When I worked with my women that were case managed that got sober, I really encouraged them to breastfeed, but I also encouraged them to stop breastfeeding and go immediately to the bottle if they were thinking about drinking again or relapse. So that's, to me, it just depends on the level of alcohol use that's going on. But again, you do need to know how to really get to that amount.
And I certainly agree with everything Pam just said. And look, here's the thing. Alcohol is a neurotoxin, okay? It kills or changes brain cells as they're developing. If a grown-up uses alcohol, then smokes marijuana, we get a synergistic effect. So it's not a plus effect, it multiplies the effect. So people get a lot higher when they use both. We believe that the same thing happens to a fetus when it's exposed. And then if you add in poor nutrition, lack of prenatal care or stress, all of that can we believe, make put the fetus more at risk. So the more we can really promote the idea of abstinence during pregnancy and breastfeeding, then we can eliminate the possibility that you can have a child that has some sort of issue and you feeling responsible. So for me, it's just don't take the risk. It's just not worth it. It's not worth the risk of having to think about and worry about if it was something you did that caused your child to suffer in any way, shape, or form.
All right, we have 2 more questions and then we'll be done. The next one is part 2 from Richard that I didn't ask earlier, and he's asking how we can intertwine with our patients in talking with them about their alcohol use and how alcohol consumption may have an effect on other medications. How can we talk about that with them?
This is Pam. I think that's a great question because I've had folks say, well, do I really need to ask about their alcohol use? And I think that's one of the reasons why we need to be asking. It's not only to prevent an alcohol-exposed pregnancy, but there's many medications that are impacted by alcohol use. Certain medications, it's absolutely counterindicated to drink and take that medication. Tylenol is one of those. I think there's antibiotics out there, again, that you should not be taking. So I think by doing the alcohol screen, if somebody asks, why are we doing that now? It's easy to say that we're starting to screen everyone for alcohol use because of the fact that alcohol can and does play a role in certain medications that folks are on. So we want to be sure to not prescribe or have you not drink while you're taking this medication, as well as having a better understanding for that the mother and father if they are planning a pregnancy or are pregnant. So I think that's a great way to really actually introduce the subject matter.
Okay, and our last question comes from Ashley, and again, this is for you, Pam. Can you mention the name of the validated screening tool specifically for pregnant women?
Oh boy, the one I believe that is the TWEAK, the TWEK, and the T-ACE. Both were looked at. They were originally looked at for pregnant women, and even the CAGE, I believe, they all started out for screening pregnant women. So any of those 3 are good screens. They're sensitive and specific. But if you're going to use those screens, they must be used prior to asking the frequency quantity question, or it invalidates the screen. So it's the CAGE, the TWEAK, or the T-ACE.
Okay, great. It looks like that's it for our questions. We do want to thank everybody for their time today. We do have a lot of people commenting that they're really appreciative of this presentation. They really enjoyed it. It was informative. So thank you, Pam and Kathy, for your time today.